Welcome to the AUA News Inside Track podcast, an official podcast of the American Urological Association. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.
Hello, my name is Minhaj Siddiqui, and it's my pleasure to open up for this episode of AUA Inside Track, where we'll be discussing a timely and important initiative that you may be eligible to participate in regarding improvement of cancer care delivery in bladder cancer. Fortunate enough to be joined by Kristen Scarpetto and Chad Rich. I'll start off by just introducing myself. So as I mentioned, I'm Minhaj Siddiqui, and I am a chief of urology at the University of Maryland, where my practice is in urologic oncology, primarily in prostate and bladder cancer. I will now pass it on to Kristen to introduce herself.
Thanks, Minhaj. I am Kristen Scarpetto. I'm a urologic oncologist at Vanderbilt University Medical Center. I also primarily focus on prostate cancer as well as bladder cancer. And it's been really great working with Minhaj and Chad, and I'm grateful for the opportunity to share this today.
Thanks, Minhaj and Kristen. Thanks for having me. I'm Chad Rich. I'm a urologic oncologist as well, and the chair of urology at Cleveland Clinic in Florida. I'm really excited to be here talking about a topic, both quality initiatives and bladder cancer, two topics I'm very passionate about. So thanks for having me.
Wonderful. So, we have been working together now for like 3 or 4 years, I believe. And what brought us together was various entry points into the Commission on Cancer. So I think that would be a way to start this conversation. The COC, which is a branch of American College of Surgeons, has these things called quality measures, and we work together on establishing what are called the urologic cancer quality measures. And so the American College of Surgeons has developed tools and resources for enabling cancer programs, like best quality care in cancer delivery. So, for people who may not know, nationally, about 1,500 hospitals are COC hospitals. And we'll talk about this in a second. This actually is something urologists should know about, and is actually extremely relevant right now with this initiative we're talking about. It captures about 70% of cancer care in the United States. If your hospital is a COC hospital, it ascribes to various standards of care and quality measures in cancer care delivery. Those quality measures are developed by a committee within the COC. Each measure is made by specialists. So there's 30 measures that span the entire spectrum of cancer care. 3 of the measures are urologic cancers. So from 2021, 22, I want to say, through like 24 when they were released, myself, Kristen, and Chad, we were part of this team as various delegates within the COC that oversaw the development of these 3 urologic measures. So there was a prostate measure, a kidney measure, and a bladder measure. And for today's conversation, we're going to really focus on the bladder measure. So Kristen, you were really the person who was leading up the bladder measure conversation. So why don't you kind of take it from here?
Okay, thanks. Just really exciting to get a sense for how this works. I think all of us in urologic oncology want to provide the best quality, highest quality care for our patients. And so learning from the COC and other surgical specialties about how these measures were developed was really kind of cool and fun. Chad and Minhaj and I each kind of tackled one disease organ within urology and formed a multidisciplinary group. So in the case of the development of this bladder measure, we reached out to urologic oncologists, medical oncologists, and radiation oncologists to kind of share ideas and brainstorm about areas where we may not be meeting the mark or delivering the highest quality care despite available evidence indicating to us that certain practices benefit our patients. So why are these gaps in adherence present? And so when we were looking at bladder cancer, We looked at things like the use of neoadjuvant or adjuvant chemotherapy for patients undergoing radical cystectomy. We looked at the timeliness of chemotherapy for patients with more advanced disease. And then one topic that really kind of rose to the top was the use of intravesical chemotherapy perioperatively for patients who are suspected to have non-muscle invasive bladder cancer that's low grade. And we all know in bladder cancer that, 75, 80% of the diagnoses each year are non-muscle invasive bladder cancer. That tends to be something that recurs at a really high rate. And there's high quality evidence showing that using intravesical chemotherapy perioperatively, particularly gemcitabine, but also mitomycin, decreases recurrence rates pretty significantly. And when we looked across these COC institutions, and as Manoj said, this captures, 70% of cancer patients, adherence to this guideline is really low. And it is a guideline. It's mentioned an important part of NCCN. It's in the AUA SUO guidelines. It's not where we want to be. And so this really was voted upon to be kind of a place where we could have a really big impact if we adopted this as the measure. And so that's kind of how we worked through it, what we decided on, how we worked to get to where we are today.
Yeah. One thing that was really striking, a lot of cancer measures are based on not as strong evidence as this measure is. This is based on level 1 evidence. I led the Messing trial, where it was randomized saline versus gemcitabine. I think they had like a 56% recurrence improvement with the intervention, which really, I mean, you don't get a lot of cancer outcomes interventions with that kind of outcome. And so to have a level 1 evidence guideline recommended care and the percentage utilization, actually, Chad, you're going to talk about that in a second. Like it was striking how low nationally this utilization is. And so one of the things we look at, just to augment like what Chris was saying, is like, when you're picking cancer measures, you're not only looking for like best practices, but you're looking for best practices with room for improvement. That's what makes it a good quality improvement measure. So it's great if something's a best practice, but if 99% of people are doing it already, well, I mean, that's great. Like everyone's already doing it, but to find the things that's a best practice, but there's a lot of people still not doing it. That's really where you can move the needle. So yeah, so Chad actually then did some great work in terms of understanding how utilization was taking. Well, so this meant live summer of 2024. And one thing that you should know, I mean, a lot of people are not familiar with COC. Certainly we weren't. I came at COC through getting involved with the American College of Surgeons through various other initiatives and slowly worked my way through the organization. And you can either become part of the COC as a delegate from a member organization, or directly elected in. So I was actually directly elected in. And then, I mean, we have a really nice diversity here because then Kristen and Chad, you both actually, why don't you tell us how you came into COC work?
Yeah, sure. So, I came in through the SUO. So I'm the SUO representative to the American College of Surgeons. And through there, I decided to join as part of the Quality and Data Assurance Committee. And that's when I met you guys in the process of doing the measures.
Yeah, and similarly, I am the AUA representative to the COC.
And it's worth highlighting, a lot of this work we did is through COC, but AUA actually was a really helpful partner, and the AUA Quality Committee, they were very supportive of providing us names of some of these people who are active in the AUA community who do quality work that we were able to bring into this initiative, and it helped kind of align some of the efforts taking place on the COC side and the AUA side. So that, that was very much appreciated. But once a quality measure goes through, it becomes part of the NCDB, National Cancer Database, where you can pull the compliance very easily. The data collection is already done, so it's very powerful. So that's actually probably the segue for Chad now, where he did actually have his team pull, and then we can talk a little bit about there.
Yeah, no, happy to talk. I mean, I remember when we were doing this, formulating the measures and the questions were asked, and we started to look at that compliance, and everybody was scratching their heads like, wow, could it really be that low? And like, what's going on? And we looked at the timing of it. And Minaj, you had mentioned that messing trial when it came out, which was, I think it was published in about 2018. And looking back at the NCDB, you'd have expected that, okay, we got level 1 evidence. We should see some uptick in utilization after, big JAMA study was published. So, with the help of you, Kristen, and framing these questions, we decided to look at the NCDB and drill down a little bit deeper and say, okay, what is the utilization trend from the time of the messing trial onwards? Now, NCDB, it takes a little while for it to get all the data in. And so even though we're tracking all this stuff up until now, they only had up until, at the time of the publication, until 2020. So we had like 3 years worth of data. And, the utilization was about 20% in 2018, and it barely moved. I think it got up to 23% in 2020. So despite publication of level 1 evidence, not much of a jump across NCDB sites. And again, keep in mind, these are like, COC institutions. And then we drilled even deeper to say, okay, could we find a reason why? And interesting enough, 2 things kind of stood out. One is that, rural areas tend to have decreased utilization of peri-op chemo. And another thing that sort of stood out is that integrated cancer networks. Now, these are sort of like big health facilities that across all the facilities, they're integrated in their approach to cancer care. They tended to be more strongly associated with the use of peri-op chemo. So kind of, supporting the idea that if you have an integrated cancer network with multidisciplinary care, you have clinical care pathways and facilities. And I know we're going to get into how to make this peri-op chemo use more seamless, but it seems like in these sort of network facilities, they tend to do a better job of peri-op chemo based on this study. So interesting findings, and hopefully with this upcoming quality guideline study, we'll see even more.
Yeah. And so, I think actually being mindful of some of the time we have to cover the rest of the material, I'm going to jump into, this became the segue to really advocate. This was a cancer measure, and we wanted to take it from a cancer measure to something that the COC does, which is a quality improvement initiative. And so we started actually trying to advocate that this should not just be a cancer measure, which went live in 2024, but a quality improvement initiative. The COC runs one quality improvement initiative a year, period. Not like per disease space, but just globally. So it's a very powerful thing, and many thousands of people, like patients, get enrolled into these things. So if you become the quality improvement initiative, it's very helpful. They wanted to see a pilot study to understand, like, if this is really something that is amenable to QI work, because sometimes some things are more amenable than others. So we ended up doing a QI initiative to understand what the challenges are within the Maryland system, with 5 hospitals, 1 rural hospital, 2 suburban hospitals, and inner city hospital, and a VA hospital. And we process mapped out the process and figured out where the sticking points are, and it became clear, actually, the reason why this is such a hard thing to do nationally, even though it's recommended, is it's deceptively hard to set the infrastructure up. You have to coordinate the care of, like, the urologist has to put an order in. The ability for a urologist to put an order in for chemo is not always straightforward. That has to go to a chemo pharmacy, which transports the drug to the OR pharmacy, which then OR nurses don't, or PACU nurses aren't always trained to dispose and handle chemo. So you have to figure out how that's going to be done. There's like training involved with that. There's essentially 4 different phases of care: pre-op, OR pharmacy, and recovery area, all of which are involved with numerous stakeholders. So after we process mapped it out, it did become clear that it is a manageable issue. It's just a complex issue. And this became the foundation for ultimately the National QI initiative. So with that in mind, this is now the 2026 National QI initiative, and your hospitals for the listener are if you're at a COC hospital, and you can find out if you're at a COC hospital by Googling. Google find an ACS accredited hospital. Okay, that's the easiest way to figure it out. I found out, and it'll pull up a website, FAS, like find the hospital, and then type in your hospital, and it'll see if you can see if it's a COC hospital. If it's a COC hospital, you almost certainly have a cancer committee in your hospital. Urologists aren't always aware of this, and they're not always involved with this, but there's so much resource involved within this type of committee. There are project managers, essentially, cancer care liaisons, tumor registrars. There's a data infrastructure already in place. There's like all this stuff in place. There's a quality improvement project manager in your hospital's cancer committee. And they are heavily incentivized this year to, as part of like reaccreditation for COC, to participate in a quality improvement initiative. And so this project is available to them, and you can approach your cancer committee to see if they would be interested in participating in this as a QI initiative. And you can actually get the data on your compliance through your cancer committee. It's already available. You don't have to like do chart reviews. You literally just ask them. There's like a field in NCDB where they can pull up your current compliance, and you can see where you fall in comparison to the rest of the country. And so it's logistically, part of like what we're doing this podcast for is to raise awareness. The notice for intent to participate is due February 15th. So this is a timely thing. And if you're interested, you got to touch base with your cancer committee, find out who your cancer committee is, and touch base with them, see if they would be interested in participating in the COC initiative. It's open to everyone that's a cancer center, essentially. There's some caveats. You have to have done 10 TURBTs, but that's about it. So, turning this into a quality improvement. I mean, Chad, you have a lot of experience with managing quality projects in urology. What are your thoughts as you transition from just a measure to a quality improvement project?
Yeah, I mean, I think, the quick take home here in the last couple of minutes we have for any listener is really, look, quality improvement projects, quality initiatives are really straightforward, simple, evidence-based things. And this is probably one of the best ones we have, currently in at least urologic oncology, that can have a huge impact. And it also is not just about, national, it's just think about within your institution, finding where the gaps are, finding where the challenges are. We should all want to improve what we're doing now. And if you're struggling to get that high rate of intravesical chemotherapy, then you're going to want to do, join this.
Yeah. And, one thing that I will add is sometimes some of the hard work with QI projects is that having some infrastructure to help you, because otherwise it falls all on you. One nice thing about a project like package like this is a project that automatically comes with hospital resources. So no matter which hospital you're at, if you're a COC hospital, joining this project will let you help solve this problem, not just on your own, but actually with a project manager that comes through a cancer committee. So that's, with quality expertise usually. So that's a nice way to do that. Kristen, I figure I would ask you as well, like, what are your thoughts on, you also have experience with just kind of, having been more involved with the COC and whatnot. Can you share some thoughts on why would one want to join this type of endeavor, and like, what are the benefits that they can gain?
Yeah, I think really what it comes down to is providing high quality guideline concordant care for our patients. And I think if you're a COC member institution, you are likely very aware of the data and what the guidelines say, but you may not be aware of your own institution's performance. And I think that there is a little bit of a disconnect, and by a little bit, I mean a huge disconnect between knowing what the guidelines are and then actually delivering the care that we know is going to benefit our patients. And so I do encourage you to join on, take a look at what's happening. And if there are gaps in adherence, figuring out where along that pathway that Minaj pointed out, the gaps or limitations are, and then either working locally or using these resources that are readily available, collaborating. Like, part of what's so great about being in urologic oncology is that we can share ideas and work together, this is an awesome opportunity to say, hey, this is what's happening at my institution, and this is why I'm having these problems. Someone else is having those same problems elsewhere and has maybe already learned to tackle them. So this is a great way where we can develop strategies together to improve this adherence and therefore improve the care that we're providing to our patients.
Wonderful. Well, I think we'll close it out. So again, if you're interested, look up if your hospital is a COC hospital. Again, it's not all academic centers. Actually, about 60% of these hospitals are not academic. So there's a very strong enrichment of community and rural hospitals in the COC. So your hospital may be a COC hospital, your private practice, wherever. This is not an academics only project, certainly. So to summarize, what we've talked about today is a national QI initiative for improving bladder cancer outcomes that you very well can participate in and hopefully take advantage of a lot of institutional resources to get help in making your own care much improved for bladder cancer. So this is, again, a timely initiative. Your hospital needs to enroll by February 15th. You can find out more information by Googling TAPT QI, okay, to TAPT space QI, and that'll actually pull up the first link that comes up is the TAPT National QI, National Quality Improvement Project by the American College of Surgeons, and that's the headquarters website for all the information that you will need. The other thing you need to do is find out your hospital's cancer committee. Okay, there's most likely someone who is designated as a CLP, Cancer Liaison Physician, and that is the point person between your institution and the Commission on Cancer. They are the ones that have to sign off on your institution enrolling in this QI project. And in general, you will need the supporters committee to implement this project. So it's a whole process. It's a way to learn about institutional resources available for QI work. It's an opportunity to get involved with more organized, kind of structured QI work, and it's a great way to improve bladder cancer care at your institution. So we hope you will be able to participate.
This has been an AUA News Inside Track podcast. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.